Joining right now. Welcome, everyone. Thank you so much to Dr. Devinsky for hosting this webinar for us. We know how busy you are, and it's so important that our community can hear from you as we launch the first trial ever for FOXG1 syndrome together. So this is really exciting because, as you know well, that we really only launched all this work, well, now it's 6 years ago, and epilepsy is a major concern for most of our patients. To those who don't know, I'd like to introduce Dr. Devinsky. He leads the NYU Comprehensive Epilepsy Center. I'm very fortunate that he is Josie's neurologist. When we launched the FOXG1 Research Foundation, he joined our scientific advisory board, which I could go on and on how valuable that has been for us and really helped set us on our way. So we learned about Fintepla being a new epilepsy medicine. And as our community knows, we're always looking for that medicine that is going to, help our children and help us get closer to seizure free. And when I learned about the great results we were seeing in Dravet and Lennox-Gastaut, Dr. Devinsky and I talked about trying this for the FOXG1 community and really seeing through a trial how it impacts our community. Then we just talked about how, patients would have to come to New York to be part of the trial. So part of the delay in launching this trial is because we discussed together a way to be able to invite any patient to take part in this trial. And that is what Dr. Devinsky is going to speak to you all about, how you can be a part of this and access this medication and, learn to see if it could be effective for your FOXG1 child. So I will turn it over to you, Dr. Devinsky, to introduce more about Fintepla and what it means and what the trial means for our community.
Well, thank you, Nicole, for the generous introduction. And the other delay I might add in getting this off the ground was that the company we started the project with, Zogenix, which makes Fintepla, was purchased by UCB Pharma, and totally different team involved, a different process. So that held it up, and we shifted gears so we could try to include patients who are geographically isolated from New York City and who would not have to do travel to join the study. So let me walk through it. And this study is fenfluramine for the treatment of convulsive seizures in patients with FOXG1 mutations. So some background on fenfluramine. It's a synthetic amphetamine analog. It was approved in many countries to suppress appetite in adults with obesity, typically combined with another compound called phentermine, which is also a stimulant, amphetamine compound. And together it was found in the late 1990s that there were cases at far higher doses than were ever used in epilepsy of both heart valve and abnormalities and pulmonary hypertension, leading to the combination or fen-phen, both drugs, to be removed from markets. However, in the 1980s, some physicians in Belgium started treating patients with Dravet syndrome with fenfluramine and found remarkably good results. And as many of you may have known, the studies in Dravet were by far among the most positive seizure reduction studies ever done in epilepsy in randomized controlled trials. Subsequently was also found to be effective in Lennox-Gastaut syndrome, although the difference between active compound fenfluramine and placebo was not quite as robust. So this existing evidence, we have some, interest in FOXG1, and it's been previously approved, as I said, in Dravet and Lennox-Gastaut and other rare neurodevelopmental epilepsies. I should add that the heart valve issues and pulmonary hypertension have either been entirely absent from the pediatric populations, and this includes patients treated in Belgium now for, I believe, over 20 years, as well as many in America for nearly a decade. So we've got pretty good safety data, and I think given the risk of uncontrolled seizures, which range from cognitive impairment to falls with head injuries to sudden unexpected death in epilepsy, the safety of this compound is actually fairly good. So here's some of the data that we have from the previous randomized controlled studies. This is a study by Legay, who's the first author in 2019. We were one of the sites, and I was one of the co-authors. And what you can see is the change in convulsive seizure frequency difference from placebo for the high dose 0.7 milligrams per kilogram per day was 62.3%, which is incredible. Many drugs, I was involved in the Epidiolex or cannabidiol studies, we were looking at 20 to 25% greater reduction than placebo. So this was really quite a dramatic finding, and you can see the significance value point less than 0.0001, highly significant. Same with greater than 50% reduction in seizures, which was 68% on the fenfluramine and 38% on the lower dose and 12% on the placebo. So again, a dramatically increased change, 68 versus 12 regarding placebo, and similar things for longest interval of seizure-free days. So again, a very robust study, very strong findings. We did a small trial, which is not dissimilar to what we're doing here, using fenfluramine for CDKL5 deficiency disorder patients. And you can see on the left, we have 5 patients who had tonic-clonic seizures. The median reduction in those major convulsive events was 90%. And for tonic seizures, there was an average of about 55% reduction, with only 2 patients having that seizure type. So again, very encouraging, and there is a larger randomized controlled trial of fenfluramine for patients with CDD, or CDKL5 deficiency disorder. So let's turn now to the present study. And the goal here is to evaluate fenfluramine in patients with FOXG1 mutation. They need to have a confirmed mutation diagnosis, so we'll need to look at the genetic report. They have to be between ages of 2 and 35 years of age at the onset of the signing consent. They need to have stable anti-seizure medications for at least 4 weeks before starting fenfluramine, and those need to remain stable during the initial 14 weeks of the study. They are eligible if they receive between 1 and 4 other anti-seizure medications. So they can't be on no medications, and they can't be on 5 or more medications. They could be on 1 to 4, which is a pretty liberal set of criteria. And very key, they need to have at least 4 convulsive seizures in a 4-week period. And these can be tonic-clonic, tonic, atonic or drops, clonic or jerking limited to one side, or focal motor seizures. All these seizures that are counted, these 4 or more seizures, have to last at least 3 seconds. So we're not talking about little sudden myoclonic jerks, which are convulsive seizures, but they're so hard to count, we were afraid the noise could exceed the signal and could bias the result negatively. What are some of the reasons that patients can't be in the study? They have an existing cardiovascular or cerebrovascular disease. There's a history of a heart attack, myocardial infarction, or stroke. There's a history of anorexia nervosa, bulimia, or depression within the prior year, a history of glaucoma, a risk of self-harm or harm to others, or the patient's taking other centrally acting drugs to reduce appetite. And those would include, for example, stimulants for ADD, ADHD, just as one of the potential exclusionary criteria, which probably not too common in this population, but certainly may occur. And this busy slide I won't go into for detail, but let's just kind of walk through what would be happening here. So what you see at the top, which is probably most important, give you an idea of what the visits would be. There's a baseline where we review the patient's diagnosis, obtain informed consent, review the inclusion-exclusion criteria, get the medical history, get basic demographic, age, sex, diagnosis, have a physical exam and vital signs done, review for adverse effects of existing medications, go through some standard, relatively short scales that look at quality of life or global impression of how the child is doing or young adult, and then get blood work to look at existing medication levels, give the study diary out, and review how the study will work between the coordinators and the investigators and the parents who are involved. And then there'd be a safety call after that, just to review some again, inclusion, exclusion, and the adverse events. And then week 2 would begin, medication would have started already. Week 6, again, these are just the visits. There's a safety call, week 10. And those week 2, 6, I should say baseline 2, 6, 10, and 14 are visits where the child and the parents would ideally be visiting with the physician, which can be locally in Detroit or San Diego, or here at NYU if they live in the tri-state area. We would work with the collaborating physicians, and we'll go over that. The protocol itself would be signed by the parents. They would not be officially part of the study. They would be agreeing to see the child as a clinical visit, but obtaining this data at the bequest of the parents and our investigation. Sorry. So the starting dose will begin at a low dose, 0.2 milligrams per kilogram per day. It's typically given as a liquid, 2.2 milligrams per ml. So it's a small volume, depending on the size of the child. And then days 5 to 8, it increases to 0.4. And by the end of 2 weeks, the child is on the full 0.7 milligrams per kilogram per day, or 0.35 in the morning and 0.35 at night. This dose would be maintained for the subsequent 12 weeks, which would be the key data period that we would be comparing to the baseline data before the fenfluramine was added to the child or young adult's anti-seizure medication regimen. So I think some of the most key logistic questions and where this differs from most clinical trials is we worked hard to accommodate patients who would not be treated at our center for logistic and travel reasons for the families. It's not a lot of visits for a study, but it's not a trivial number. And if you live in California, doing 5 or 6 round trip tickets to New York or moving here for 14 weeks is not ideal. So what the neurologist would need to agree to is complete recommended study visits, and we could share everything with them, what's needed, order the laboratory. A lot of this is standard blood work, like complete blood count, comprehensive metabolic profile, seizure medication levels, help with some of the questionnaires. It should be a relatively light lift, and the children will need baseline echocardiograms, and then echocardiograms towards the end of the study. They would be prescribing fenfluramine under the Lennox-Gastaut syndrome REMS program, which should be a relatively straightforward, diagnoses cut both ways. I would strongly argue for groups like CDKL5 and FOXG1 that although the children technically meet criteria for Lennox-Gastaut syndrome, which is an okay label for them, they really are different, and they have a specific gene mutation that makes them different. And if there's a gene therapy for CDKL5, it will not be appropriate for FOXG1, and vice versa. Your gene therapy will not be appropriate for CDKL5, Dravet, or the other 120 neurogenetic epilepsy syndromes. Those neurologists would help provide records and reports to our study team, and also let us know if there are any side effects that they observe, or if they make changes to anti-seizure meds or other meds. Not ideal for the anti-seizure meds, but certainly if they happen, we want to know about them. And then provide medical records, including the history, diagnosis, and treatments prior to the study and during the study to the study team. So just some questions and answers. I know you'll have your own, but we wanted to prepare a few. How many patients can be in the study? We're planning on up to about 20 patients with confirmed clinical and genetic diagnosis of FOXG1. How long will the study be? Well, the study is now IRB approved, and it's live and ready to go, which is why we're here today. And the duration of the active study will be 14 weeks. And then I think continuing your child or young adult on fenfluramine after those 14 weeks is going to really be a decision that the family and treating physicians will make. The study will officially be over. But if people think that it has been beneficial for their child, then as with any medication, I would argue it's well tolerated and helpful, they should continue. If it's either not well tolerated or not helpful, they should probably discontinue. And sometimes it's kind of in between and not so easy, but you do your best to make a decision together with your treating physician. Can people participate who do not live near NYU? And the answer is yes. As we said, the consents, the visit safety calls can be done either in person for people who live near us or virtually for people who live outside. Will people need to switch their doctor to myself or other people at NYU? And the answer is no. We will not take over the primary clinical care for any of the patients. All of that will be done by your local neurologist, who will need to agree to help out with completing some parts of the study, like supplying medical records and some of the questionnaires. And as I said, it should be a light lift, and any neurologist or treating physician who collaborates would become an author on any manuscripts that come out of this data. So we are happy to collaborate. We want to be generous with the physicians who are obviously helping your children and helping the study move forward, but they would not be officially, they would not need to do an IRB. It would really all be done through our IRB, and they would be collaborating with us in a non-official study capacity, but they would become authors. So this is our contact information, and I will stop sharing now and really open it up for questions from anybody who is out there who would like more information.
Great. Yeah, so I see we have a question here from Natasha. So I have heard from several parents overseas about how if they could take part in this study as well. And then I'm realizing there's a difficulty in accessing the medication as far as insurance is concerned. So Natasha here is saying she doesn't think any financing will be available. So is there any funding, or do they have to arrange that themselves? So how do patients overseas access the medication?
So unfortunately, right now, the budgets that have been worked out do not include any free medication. I think it's something we can go back and, depending on the interest, if there's multiple people in foreign countries who cannot access it, who are interested, we can certainly make a request to UCB, but it's been a long process, so I don't know what the answer will be, and I don't know, it may take 6 or 9 months to get the answer, but we're happy to ask it. It's not part of the study at this time.
Okay. But the Fintepla is available overseas, right? I could have.
It's available in many countries, but not all countries, and I certainly don't have the updated current list, but people can check either by Googling or asking their local neurologist, who will likely know, especially if they're an epilepsy-focused neurologist, they should definitely know.
Okay. And so parents have also asked what kind of side effects have been commonly reported with Fintepla. So what are they looking out for during the study?
So I would say, in a positive way, the big fearsome side effect is something with the heart valves. That's not really been an issue. I was part of the studies, as you saw. I think that paper was published in 2019 or so, but the study started in 16 or 17. A lot of my patients have been on it. A lot of Dravet patients responded so dramatically, families couldn't be pried away from it because it's been so effective in controlling seizures. And many of these kids remain seizure-free for the first time in their life for 4 or 5 years. So for that syndrome, it's been dramatic. And to the best of my knowledge, maybe one subtle cardiac, finding of questionable significance in 1 out of, perhaps 500 or 1,000 people treated. So I think the heart risks are very low. And keep in mind, the only people who had problems were obese individuals treated with dramatically higher doses of fenfluramine together with another stimulant. And it was mainly a small group of obese women who had those cardiac and pulmonary findings. The more common potential dose-related side effects, I would say this is actually one of the cleaner and better tolerated anti-seizure medications I've used. It does have both serotonergic activity and some potential effects on the stimulation pathways like dopamine. So for the serotonin part, it can be an appetite suppressant. Other seizure medications on the market like topiramate, zonisamide, felbamate are also appetite suppressants. So I think for children who are very finicky eaters, who already have trouble getting their daily calories in, this could potentially be an issue. It's usually not limited treatment from the vast majority of our patients, but I think that's probably the one potential side effect. And again, because it does work on the serotonin system, and that's involved in regulating mood, there have been some reports of depression on it. They're not common, but they've definitely occurred. But I would say, in my experience, it's been under 7%, and in the more neurogenetic epilepsies like Dravet syndrome, probably lower. It's been some of the really high functioning individuals with other epilepsies who have sometimes reported depression. But overall, I would say better tolerated than most of the seizure meds like clobazam or felbamate or valproic acid. I would say overall, most patients have tolerated it better.
That's great. And what about interactions with other medications? I've learned something about the serotonin syndrome when I was looking into it. So two drugs that both have serotonin effects, like doxepin, for example.
Right. So I think you do have to be careful. It is a broad serotonin upregulator. It increases serotonergic activity across a lot of different. Serotonin has many receptors in the brain, and they do different things. Some affect mood, some affect appetite, some affect seizure control. We think the appetite and seizure control are probably the closest linked together here, but we would need to be careful about any drug, like classically a serotonin reuptake inhibitor, like a Prozac or Paxil or Zoloft, or the generic names of those, sertraline, fluoxetine, et cetera. Those are drugs we would not recommend a child be on when we go into the study, and would absolutely not recommend adding a serotonin agent during the study. And as you mentioned, Nicole, that there is a syndrome called the serotonin syndrome, which is where the brain just gets way too much serotonergic stimulation. Happens in people taking super high doses of drugs like Prozac or fluoxetine as well. And so we really want to avoid that, and would try to avoid any drugs with stimulation or blocking serotonin reuptake, which basically leads to more serotonin in the synapse or the connection between nerve cells.
Great. Okay, so this is really interesting question from Felicia Wells, who has two daughters with FOXG1 syndrome. Her 16-year-old has clonic-tonic seizures, but they're currently controlled with 2 meds, but she would still like to participate. And I'll just get to her next part. Her 20-year-old is on 5 meds, not controlled, tonic-clonic, complex partial, and they've run out of options. So I guess the first part, would you, if her seizures are controlled, would she qualify to join the study for her 16-year-old
No,
daughter?
because by definition, they need to have a minimum of 4 convulsive seizures per 4 weeks. So
Right.
unfortunately, that's a criteria. So, the 16-year-old, I would say, count your blessings. There's not having seizures. I wouldn't change your meds, ethically for your daughter. I'd love to enroll people in the study and get it done and get the answers scientifically. But, rule number 1 is take care of the people under your care, even if you're doing research. For your second daughter, we would just need to speak. Complex partial, which are now called focal unaware seizures, are technically not convulsive. So although they can be disabling, they would prevent, someone like you or I from driving. And they're not good for people, and they can cause falls and other injuries. They're not convulsive. So technically those are, and they're just known to be harder to count as well. So right now the answer would be no. Again, as things come up, Felicia, we could consider asking for an amendment and, modifying the criteria. There are many studies that do look at focal epilepsy, and focal unaware seizures are always included in those studies. But for the neurogenetic epilepsies, we often focus on convulsive seizures. Like your first daughter has, those would be classic, either the clonic or the tonic or the clonic-tonic seizures would fit well into the protocol. But the pure impaired awareness seizures, complex partial, if there's no convulsive element, if the right arm shakes during the complex partial, then that's fine. But if the only thing is staring into space for a minute, that would not meet criteria.
Okay. And so the echocardiogram, now, obviously we understand the reason for the FDA's black box warning. There's a lot of fear out there because of the fen story. We understand that the story was a much higher dose and everything that you explained. But does the echo, if the child were to stay on fenfluramine, is the echo something they would continue to do every 6 months?
Yep, that would be recommended, by the FDA, and it's what I would recommend. Again, it's not been an issue, so to speak, but I think it's just one of those safety protocols, like people start felbamate, and although the risk of aplastic anemia, liver failure is really very, very low, we do recommend, checking frequent blood work. It's actually recommended every 2 weeks. I typically do every 3 weeks, but there's no right or wrong, and that's certainly true for the first 6 or 9 months. I think with fenfluramine, the echo should be done ongoing because it may be related to total dose, and so you want to remain vigilant.
Great. And we do have another question still from Natasha. You know, I know our European parents are eager to try it, and the cost issue is something, but I don't know if we can answer this, but how much would it cost for a parent to access this medication on their own to be part of this?
Yeah, it's a good question. I don't know. And again, depending if we can find out how many non-US people would have difficulty getting it, and if it turns out to be 5 or 6, we can go to the company and make a request to see if they would make study medication available. I think there's a chance because obviously they're selling this commercially now. They're making it in fairly large amounts. And so I think, the cost to the company for making meds available is not exorbitant. I think when drugs are being developed and they're not being sold commercially, the costs are quite substantial and can bankrupt some startups trying to supply medications long-term to patients. But I think here it's possible. I don't have an answer right now. It was not what we were planning.
Right. Okay. So, but Natasha, we could try that. We can first find out how many European parents would like to come together to then make a request to UCB to see if we can access the medication for you. We can only try by asking. Okay. So, some other. I think we really covered most of the questions. Um, Out of curiosity, so the results that we've seen in the Dravet community have really been amazing. Have you seen personally patients of yours coming off of other medications from starting Fintepla? Like, how do you?
Absolutely. Especially in the Dravet population, we've seen people come from 4 meds down to 2 meds. And in addition to coming down, most importantly, really being seizure-free and having an incredible improvement in their quality of life and their safety. So we have seen dramatic results. What'll happen with FOXG1? Obviously, that's why we're doing the study.
Exactly. Okay, and so it's open, correct? So we're IRB.
Open label, it's open, and it's an open label study. Again, just because there may be confusion. Usually when we do large trials like the ones that I mentioned in Dravet and Lennox-Gastaut, those are called randomized controlled trials, which means they're placebo controlled. And the ratio of active compound like fenfluramine to placebo could be 1-to-1, could be 3 patients will get the active study medication, although at different doses. And 1 in 4 will get the placebo. In randomized controlled trials, if they're placebo controlled, which is the vast majority of epilepsy trials that get to FDA approval, they are randomized controlled trials, and your child has a chance during the 14 weeks of being randomized to placebo, and you and I wouldn't know it. That's the goal of it. We both have to be blind, otherwise our bias could enter into the results. This is an open label study. The downside of that is that we really don't know how strong the bias or placebo effect is, but we know from other epilepsy trials that it tends to run in the 10 to 20% range, and that's, I think, what we would assume would probably be likely here. So we're hoping to see, a substantial, hopefully at least 35% reduction in convulsive seizures and hopefully much more.
Great. So our patients will not be getting a placebo. I think that's
Everyone in this trial will get fenfluramine. The parents will know what they're getting. They'll know the dose. The treating physicians will know. We will know. Everyone. It's why it's an open label study.
right. And how quickly typically do you see an impact from medications? Do you think you see something especially with fenfluramine starting at such a low dose?
So I think I wouldn't expect to see anything for the first 2 weeks, which is when the dose is really getting titrated. But I would hope by week 3 or 4, for many of these children, we'll see a nice reduction.
Okay, great. So what parents do now, if they want to join the study, their next step is to reach out.
Contact us. The contact information's on the last slide. I will put it on one more time for everybody, just so you can take some notes. And I know Nicole is very good at this, and she will circulate it as well to anyone who asks.
Absolutely. This webinar will be shared with our community. And there you have it. There's the phone number. You go directly to NYU, and they will enroll you into the study. And then we will have, real data on FOXG on how a promising epilepsy medication can impact our community, which is a great thing.
You won't have to sit in the traffic that you see on the right.
Right. That was I think worth the wait in launching this for everyone to not have to, especially in the summertime. Okay, so if nobody has any other questions, I think we could wrap it up.
Thank you, Nicole. Thank everybody who's participating, and look forward to hopefully getting some answers from your community and starting the first trial, which hopefully will be the first of many coming up.
And thank you for everything you do for the FOXG1 community.
My pleasure. Take
All
care,
right.
everybody. Bye-bye.
Take care. Bye-bye. Thank you, everyone. I will circulate this webinar and reach out to me, of course, with any questions, Nicole at foxg1research.org.